Okay, so we're going to keep moving. This is a tough session. It's now standing between you and lunch, I understand, but here we are. I'm Morris Bearer. I'm Emeritus Professor with CHSPR, and it's my great pleasure to introduce the speaker who isn't here. For me, this is a new experience. I've never tried to introduce somebody who wasn't actually not there. In any case, we're about to hear from Jerry Hurley. Jerry is a very unusual health economist. For those of you from the persuasion, you'll know that we're viewed with something between skepticism and ridicule by the mainstream economists in the world. You'll find actually very few health economists who work in traditional departments of economics in the country. When Bob Evans, who most of you will know, retired from the Department of Economics at UBC, the Department of Economics at UBC did not rush out to find another health economist to replace him. Not that you could replace Bob Evans, but the fact that I did not rush out to try to replace him with another health economist. And then there's Jerry. He started traditionally enough in CHEPA at McMaster, but over time, his remarkable capabilities and his research work received the respect they deserved. He became the chair of the Department of Economics at McMaster, quite remarkable. You have to take my word for it, but it is quite remarkable. And now, for his sins, he's the dean of the Faculty of Social Sciences at McMaster. So he is, in a very real sense, a for health economics, not only in Canada, but I think internationally. His research on the economics of health and healthcare systems has included work on physician behavior, funding models, resource allocation in healthcare, public and private roles in healthcare financing, incentives in health systems, and equity in health systems. And today he's going to talk to us about what the evidence tells us about how parallel public and private financing affects equitable access to care. So I'm not quite sure how this is going to work, but he knows he's got about 3/4 of an hour for presentation, and then we'll see how the questions work. So over to you, Jerry.
Can you guys hear me? Yes? Okay. Thank you. I apologize. I'm sorry I can't be there. We had a few things emerge in the last week or so here that's preventing me from being there. So this is the second best solution. As Morris said, I've been asked to speak about some of the economics of parallel private finance, and in particular, what does the evidence say about equity in access? And just by way of context, I want to just emphasize I'm speaking about private finance, parallel private finance. I have nothing to say in this talk about private delivery or some of the other related issues, which often kind of get tangled up here. What I'm going to do is essentially try and address this question, compared to a public-only insurance system, what would the introduction of parallel private finance, dual practice, and deregulated fees do, and how would it affect access to the publicly financed system and equity within the publicly financed system? And I emphasize it's not just allowing the insurance, but also, of course, enabling dual practice, deregulating the fees, which of course are all part of the CAMB case, and they're all part of the case for good reason, that they all will affect the viability of any system of parallel private finance. And so what I'm going to try to do is review some analytics and what evidence we have on this question. And, this is obviously an empirical question in the sense that there's no a priori answers to what would happen. It depends on other factors for which we need to draw in empirical evidence on on these matters. Further, it's a complicated question. It's not straightforward. I know the previous speaker spoke about the common sense story and the fact that the common sense story doesn't always, and I think this is an example of that situation. We have to think about what goes on and how insurance markets operate. We have to think about how healthcare service markets operate. We have to think about kind of the input markets for insurance. And all of these will play a role in determining what ultimately would happen. And there's good quality. There's very consistent evidence on some of aspects of what's important. But of course, there's lower quality contested evidence on others. And my approach to this is, we know there's some evidence, for instance, Australia's experience since they expanded the private insurance sector. We can go back historically to the UK and many countries. And that's kind of an aggregate approach that tries to say what happened. My approach is going to be to try to break it apart a bit and look at what, in some sense, what was the process and the series of events that play out when you do introduce it that determine what the outcome would be, and what evidence do we have on each of these individual pieces of the puzzle, rather than trying to just look at kind of overall evidence, because in general, we know that such evidence is, there's not a lot of it, and it is highly, highly contested because there's always counterfactuals. We're never able to control for what happens in the overall system in such a situation. So, I'm going to kind of break it apart and move through parts of this systematically, I hope, looking both at equity and access. You'll see I'm going to try and move through the equity part a bit more quickly, only because I think it's straightforward. And I think we have a very good understanding of that evidence. And although some people might debate whether equity is relevant, if you would accept at least the approach I'm taking, then I think the evidence is quite clear. And really, it's the question about what would happen to access within the public system that is the more debated question. I'll get to my punchline, which is, as I said, that I think it unquestionably reduces health system equity, and by that I mean distributional equity within the system. And my own assessment of the evidence is that on balance, it reduces access to those who have to continue to rely on the public system. Though, as I said, I understand that evidence is probably more contested than the former. So let me a few preliminary things, just to say that, of course, under what conditions will a parallel private finance sector thrive? And the first one is, if you're going to ask people to pay for something in general, not always, but in general, you have to offer them something that they can't get under other options. And in this situation, sometimes it's just amenities. You can go pay privately and go to a different facility and enjoy all these amenities if you're willing to pay for the care along with it. That's not a huge issue in Canada. Sometimes the private system and the privately financed approach would offer you more choice. In some countries, it gives you choice of doctor, a choice of facility, other kinds of choices. Again, I don't see that as a primary driver in Canada, for sure. I think the predominant reason why in Canada and many other countries, people might opt to pay privately for care, of course, is to obtain care more quickly, avoid queues that plague many systems, and get taken care of more quickly. So, part of this is to say, as others I'm sure have emphasized, that obviously it's incumbent upon the public system to do whatever it can to operate as effectively as it can with the resources it has to take care of people in a timely manner. The other side of this, that's, if you think of it as kind of the demand side, why would people demand to get care privately? You have to think about the supply side as well. Providers, of course, have to have instances privately through privately financed means. This, of course, is a target and one of the reasons why Canada has adopted the regulations of physician fees, even when they provide services privately, publicly insured services privately, is to discourage this activity. And then you also have to have an insurance sector. You have to have insurance emerge to help people to defray the high costs of care. And again, it's not automatic that insurance emerges. It really will depend in part on the size of the market factors. But certainly, in general, depending upon how such a ruling would go, there is certainly the potential, given that Canada has a highly developed private insurance sector already, that it would have incentive to try to enter this market where it would see opportunity. Obviously, Canada has chosen to target its regulations on the providers and on the insurance sector as a way to try and inhibit the growth of privately financed care. So let's then turn to the question of what does kind of analytics and the evidence say about how parallel private finance would affect equity and access. First of all, what do I mean when I speak about equity? I'm going to look at equity in three dimensions of system performance, and in every case, I'm referring to distributional equity. The first one is equity of use and access, where in general, I think the predominant notion is that we would aim to allocate care according to need within the Canadian system, as with many other publicly financed systems. And with distributional equity, of course, two notions come into play: the horizontal equity, about equal those in equal need receive equal treatment, and vertical equity, that those with differing needs receive appropriately different treatment. And both of these are critical aspects of trying to assess distributional equity and access. Not always easier. We tend to rely on use as a measure, a proxy for access. Though there has been some work trying to use direct measures of access, such as unmet need and related types of measures. The second aspect I'm going to look at is equity in finance. I'm going to argue that I think the relevant principle in the Canadian context is that contributions to finance the system should be according to your ability to pay. And again, the same two concepts of horizontal and vertical equity would apply when we think about equity in finance. And the third notion of equity, or area of equity, I'm going to focus on and discuss briefly is net incidence. And this really refers to the difference between the first two. In other words, if you look at how much people contribute and how much the value of services that they get from the system, what's the net benefit or the net cost to them when we take both sides of the equation into account. And of course, in general, through redistributional policies, we like to have net incidence whereby on net, those of lower socioeconomic status would benefit disproportionately more than public system than those in the of high income status. You could also think about this in some ways. They're correlated, of course, is in terms of even those in need, those who need care versus those who don't need care. So very quickly, running through this, I think there isn't any question that we can say that it would unequivocally reduce distributional equity with respect to use and access. There's good, consistent evidence on this from many places, so I won't belittle. Fundamentally, it arises for a number of reasons. One, of course, is those of higher socioeconomic status can self-insure and pay for care privately if they want more easily. But they also have greater ability to obtain private insurance. And that's both because they can pay for an individual policy if they want, but also we know that much private insurance in Canada and some other countries, many other countries, comes through the employment relationship. And they obviously, that would bias insurance towards high income individuals. This is a finding that is just absolutely ubiquitous across countries that allow, that have private insurance. The clear gradient of access to that insurance that favors the socioeconomic, those of high socioeconomic status. So the evidence over here is overwhelming on this point. I think the other point that's an important part of this, and for which again the evidence is strong and coming from both aggregate studies, individual level data, secondary data, as well as randomized studies, which is that providers prioritize those who seek care privately. And it's understood why they pay higher fees, often whether it's insurance or paying privately. And so the evidence is very consistent that they are given priority when seeking care from providers. And so when you, of course, combine that with the fact that you've got a gradient in who has insurance with the fact that they receive higher priority, that creates the differential equity of access within the system. And then the last point is that private insurance, wherever it's allowed to do this, strives, of course, to exclude certain users, and that tends to be users with complicated cases. So the role of duplicative insurance, parallel private insurance, is almost exclusively for uncomplicated procedures. On a relative scale, a lower need than many of those in the system. But importantly, it also excludes from coverage those with pre-existing conditions and chronic conditions. Again, high need individuals, often lower income and socioeconomic status. And then again, we're allowed to explicitly would include seniors who would be relatively heavier users. So overall, I think the evidence is very strong that because of these three factors of who gets insurance, who's prioritized, and other efforts to exclude certain high use, that would compromise allocation according to need and reduce equity. And as I say, the evidence here is strong, and it comes from many, many countries and in many systems. If we then look at equity and finance, there is explicit evidence here, but I would argue this is the place where, in fact, we have a very good understanding of what happens. And in fact, by our usual metrics, right, normally we would say we would like to have progressive contributions, that is, those of higher socioeconomic more than those of lower. And in fact, because they're the ones who buy the insurance, they're the ones who buy private care, it would, by that criteria, increase distributional equity because they're paying more into the system if they're also continuing to pay all of their taxes and so on. The proviso here, of course, is this assumes no tax subsidies and other measures that, for instance, we currently have in Canada that would often provide subsidy to those who obtain insurance, either if they get it through employment or if they're allowed to, for instance, perhaps try and get a credit or something through their taxes. So looking at this dimension alone, one could argue that it would increase the progressivity of contributions because higher income individuals would be the ones buying the private insurance and buying the private care. But of course, what matters is our policy in the end of the day in this respect is net incidence. And here, again, the evidence, I think, not as prevalent, but the analytics and the evidence all point in the same direction, that it reduces distributional equity with respect to net benefit. Because what's happening is, yes, they're contributing more, but they're also exclusively getting those additional services. Their contributions aren't being shared with any other people in the system. And so that therefore then compromises and reduces the distributional equity when we take into account both amount of use and the need associated with the user and contributions. So on balance, I think all of the evidence and all of the analytics are quite consistent that introducing parallel private insurance would in fact reduce distributional equity, at least in these three dimensions of system performance, by the definitions of equity, distributional equity that I've been using, which I think are really quite standard and quite mainstream. And I can't imagine there would be a lot of controversy over these notions. Okay, moving then on to access and this impact access. Again, this is where I think things get a bit more complicated to think through. And I'm going to, I'm an economist, so I'm going to kind of walk through it thinking through the demand sides and the supply sides of the relevant markets. I hope not getting too bogged down in detail. But in fact, this is one of those areas where one really does need to pay attention to detail because it does get complicated. And the questions I'm going to ask would be, what would be the impact on the demand for healthcare in the public system, in the private system, and in total? We have to know each of these in order to assess what would impact it would have on access to those who rely upon the public system. And then the same thing on the supply side. What would the impact of introducing parallel private insurance be on the supply of healthcare to the public system, the private system, and in total? Again, we need to know all three of these in order to understand what the ultimate impact would be on access for those who rely upon the public system. And then, of course, the determining factor is to what would happen to access the relative sizes of these differing demand side and supply side effects. Excuse me. So let's walk through some of this. And I want to start with just some illustrations to, I think what can go on and why we need to think carefully. And then I'll move on to what the general analytics and evidence are. But I want to convey a little bit about why it's important to think through this carefully. So 3 illustrations. The first one is really one of the most straightforward ones, and it's often the story. And again, it's a story in which we assume total demand for healthcare stays constant after the introduction of parallel private insurance. All that happens is some people who previously got care in the public system will shift over. So it's a pure substitution of private care for public care. And then I'm going to also assume that total supply is constant, but what happens is the equal number of units of supply shifts from the public to I just put A in here to say, A units of demand shifts over and A units of supply shifts over. And so many people would look at this and say, well, what's the harm? There's been no harm. Of course, the public system can provide the same access it did before. Some people can get care privately, and there is no harm whatsoever to the public system. But in fact, this is incorrect, I would argue, because of the prioritization process. Again, the only reason someone would pay privately to get care is because they can get it faster. And this means if the total supply to the system is unchanged, then it must be that the private system is, in a sense, giving higher priority to the private pay patients, lower priority to the public patients, and therefore you would expect reduced access, at least as measured by wait times, for those who remain in the public system. And again, I'm going to call this the prioritization effect because we know this operates in every place where you have such parallel finance. And even if everyone in the public system still gets their care, they would wait longer because they get a lower priority than the private pay patients. Again, the evidence on this kind of prioritization is prevalent across many, many systems in the world. And so here's just an example where it's a little, this isn't hugely complicated, but the common story is not quite as straightforward as some would assume. There is harm to those who rely upon the public system. The second one's just a little more complicated in that I'm going to assume the same thing. Imagine, again, all that happens is there's a substitution of private care for public care. Only now assume that there's actually an increase in supply. Providers provide a bit more than they did before. They're responding to this incentive they may have to provide care privately where they're going to get paid more. I just assume here, suppose it grows by 1. So there's still A units of demand in the private sector because that's the total amount there and there's no new demand. Therefore, if supply increases by 1, then supply to the public system is going to decrease by A minus 1. So the point here is the supply to the public system shrinks or reduces by less than the amount of care that's been shifted over. And so the question, and this is a story that would commonly be told, again, by strong advocates for parallel private finance, saying, well, look, there's going to be new supply coming into the system, and that will ensure even more than to the public plan, to those who rely upon the public plan. And again, what's interesting here, in my mind, is, of course, everyone does still get treated in the public system, or privately, of course. And in fact, here, an additional patient would get treated in the public sector over any period because of this net effect of the supply and demand. But in fact, it's ambiguous as to what would happen to access in the public plan based on wait times. Because again, we now got this prioritization effect competing with what I'm going to call a capacity effect. Yes, net capacity has grown slightly in the public system, but we have again got this competing prioritization effect, which would say, on average, people will still wait longer. And so even in a situation like this, one can't argue or conclude that, in fact, those who rely upon the public system will, in fact, be better off. In fact, you can't even argue that they won't be worse off. Again, a bit more, I think, a bit more subtle and a bit more complicated than a simple commonsensical story here would argue. Of course, they're better off. Then the last one is really the more realistic scenario, and that is total demand grows. There is both a shift in demand from public to private, and there's a whole new set of new demand privately that did not exist prior to creating the parallel privately financed system. So total demand has increased. Here, I'm just going to say, suppose supply is constant. And so A plus B units of supply has to shift over to meet this private demand, which the supply of services to the public system has fallen by more than there's fallen demand to the public system. And of course, here's the one situation in which we can say confidently that those who rely upon the public system are unambiguously worse off, because they would have a harder time getting treatment. They would wait longer because there's been a net reduction in access, unquestionably. And here, both the prioritization effect and the capacity effect work in the same direction to reduce access to the public plan. So I offer these just illustrations, they're little stories, but just to kind of help you to see why we have to really consider in some detail what's going on in each of these submarkets as well as in total. So what does the evidence say might happen? And so if I move to kind of the general literature on the demand side effects of parallel private finance, there's a few things that happen we've already talked about. One is there's a chunk of people who will continue to simply use a public plan. The vast majority of those who currently use the public system will continue to use it. There will be some substitution of private care for public that in fact would be to decrease demands on the public system and, of course, increase demands in the private system. But then there's going to be this new demand that gets generated. Some of it will come from the fact that certain kinds of public services are, we would say, complementary to private demand, and that is if you go seek care, you will also consume additional public care, whether that's a visit to your GP to get a referral, whether that's to get certain kinds of tests done publicly that will help process you along in the private system. There are these services that are in which the public system and the public demand is complementary to saying that you want to get care privately. And this will, of course, increase demands in the public system from that which would have happened otherwise. And then there's going to be completely new private demand of people who never would have sought care through the public system. So, what's likely to happen on net? Well, we have very, very good evidence. I mean, the first two effects under existing demand are completely well documented. We know that's what's going to happen. On new demand, we know it happens with complementary public demand. We don't really know the magnitude, or we don't have good estimates of the magnitude. And similarly with private demand, what we do have is I think good evidence that total demand will increase for sure. Private demand, of course, will increase, and public demand will likely decrease. But it's important; it's going to decrease less than just this pure substitution or shifting of public into private. And so, it's what's going to be really important is, will the supply side respond? If total demand increases across the two sectors, will there be an elicitation of new supply that can, in some sense, compensate for the increase and leave access in the public system no worse off than it was before? And so, looking at the supply side, just running through the same kind of analysis, again, a little more complicated. And here's where we're getting into some areas where I think there'll be some components where the evidence is a little more contested than some of what we've seen thus far. But the most important point is, of course, these are services, particularly obviously physician services, that are for which the physician, the health professional are the most important part of the production and the delivery of the service. So a lot will depend upon the work decisions of the healthcare professionals. And there's a couple of kinds of decisions that are important. One is what I'm going to call total work effort. And that is, do they decide to work, if you create a parallel system of finance that offers higher fees than is offered through the public plan because they've been deregulated and physicians can engage in dual practice, how will that affect the decisions a physician makes about the total amount of work effort they're going to offer? In language of economics, the decision between working and taking leisure of any non-work time. But then there's also going to be incentives to change how they allocate their time when they are working. And that is the decision between how much care do they provide in the public sector, how much care do they provide in the private sector, and how much non-clinical professional activities will they undertake, whether that's administration, education, and so forth. Because they can choose to reallocate time within their overall work effort. What's the evidence? What evidence do we have on how physicians might respond when you introduce finance with a higher paying private sector? In terms of the question of will they work more or work less, or will it elicit more work effort or less work effort, I think there's two competing effects that we would identify at work here. One, we call it the income effect, but because they would work less. And the easiest way to think about this is they now get higher income per hour of work if they spend time in the private sector. Therefore, it takes less work effort to reach what you might call their target income, or since that's a charged word, you might just say their disease. And therefore, it gives them incentive to actually reduce their work effort overall because they get paid more per amount of time they're working and can reach any income aspirations with less work effort. Then there is a competing price effect, which says, now more value to working compared to taking leisure than there was before because I can earn more money. I get paid more per hour than I did before, so maybe I'll work more. So these effects work in competing directions, and it's ambiguous. Again, we can't say for sure without looking at the evidence. And the evidence, I think, is pretty consistent and pretty strong in the sense that it would predict probably little or no impact on total hours of work. And I'm drawing on two basic kinds of studies for this. One is there's a lot of studies of how physician labor supply responds to fee changes. This isn't necessarily in the context of parallel finance, but how do they respond when they face fee changes? And some of them actually show them working less, some of them showing a bit more. Some recent reviews of the evidence would suggest that there is a very small response in either direction. So out of this context, it says very little response to total work effort. And there's two studies I'm aware of that looks in the context of dual practice and dual finance in Norway and Australia that also find little or no response to total work effort as they change fees in earning opportunity in one of the sectors. So I think it says the best bet is no. Certainly amongst those who are working, I would argue more people might decide to work. They'll retire later. They will, stay in BC instead of moving to the U.S. Those are things over which we have no evidence whatsoever. When we look then at the second part of the overall challenge, how do they allocate work effort? We know they have incentive anyway to reallocate effort from non-clinical to clinical care in the private sector. For many physicians, this would be relatively small. I mean, unless you're an academic physician who does a lot of research and teaching, there isn't a huge amount of scope to do this. But then within the time they spend providing clinical care, there's obviously incentive to reallocate from clinical care in the public sector to clinical care in the private sector. And this would be obviously the pure kind of price effect happening where they can earn more per hour working in the private sector. And all of this is, I'm abstracting the fact that some physicians would, of course, be against working in the private sector whatsoever. We're talking on average across all physicians in the system. And in the evidence, we really have one, I would say, good study of this. It comes out of Australia, although it was actually published in the Canadian Journal of Economics. That in fact, total work hours is unchanged, but they reallocate hours to the sector that pays more. And in fact, they're more responsive to increases in pay in the private sector than they are to increases in pay in the public sector. So what happens is we would see no growth overall in work effort, just a reallocation from the public to the private sectors. And so if you add these two together, increased total demand, little evidence that they would do anything other than just simply reallocate. They won't increase total work effort. The net result is reduced supply to the public sector and reduced access to the public sector for those who rely upon the public sector. So it's this chain of reasoning. It's a set of factors and the evidence that we have on each of these dimensions, which it really underlies my conclusion that on balance, it would result in reduced access for those who continue to rely upon the public sector. There's one other part of this, and then I'll go towards wrapping up because I must be close to half an hour now. And this is the fact that there will be increased cost pressure, and that will work to reduce the real value of the public budget, because now you will have two sectors competing for these healthcare professionals. And when you're competing with another to get their attention and their work effort, it leads usually to higher wages. And this would then reduce the real value of the public budget and reduce its ability to deliver services and purchase services for those who continue to rely upon the public system. The evidentiary base for this effect is not strong. We do see patterns of behavior very consistent with this, where, for instance, in both the UK and Norway at various points in recent history, has had to substantially increase wages in the public sector to try to draw more work effort from providers into the public system because it had been moving over and shifting over into the private sector. And then interestingly, some work we did years ago now, 15 years ago at least, where we were looking at the role of workers' compensation and so forth. And we actually saw evidence in BC, at least reports of negotiating strategies in which physicians explicitly tried to get high fee settlements in the workers' compensation sector before negotiations in the public sector to try and drive for higher compensation and demands in the public sector. So we saw behavior very consistent with this when we spoke to, when we looked at what was going on in British Columbia and some other provinces. My last slide. Can these effects be mitigated? And I think the answer is partially. One could try to limit the size of some of these effects, but none of these efforts would be as effective as the current regulatory regime that Canada has. If we had to try and resort and look at other options, one could consider, for instance, tax policy, where first of all, we're removing the subsidy, making sure we don't subsidize the purchase of parallel private insurance. But one would consider imposing a tax. I mean, this is a standard case in which the purchase of this product, the parallel private insurance, and use of the parallel private finance system is imposing an externality or imposing spillover effects into the public plan. And so a standard kind of response is to try and tax that activity so as to reduce the amount of it that takes. It wouldn't take it to zero, but it might be something one could try. These certainly aren't the kinds of environment context, political context where tax increases though are accepted well. So I don't know how what the scope would be for that. One could try to regulate the products that could be offered. You could regulate benefit packages. You could again regulate conditions about needing to offer policies without any discrimination towards seniors, those with pre-existing conditions, and so forth. And that again, I mean, on one hand, it might increase access to such insurance because more people would get it than if you left it to devices of the insurance industry. But it might also make it less attractive to offer this insurance. And then, of course, a no-brainer would be simply to make sure for certain that public facilities can't provide privately financed care as they're allowed to do in some countries. So, there are some possible responses, but as I would emphasize, I think that they would at best partially address some of these challenges and are clearly less effective than the current regulatory regime. So I'll stop there.
Okay. Thanks very much, Jerry. We're running a little bit over, but I'd like to give everybody an opportunity to get in a couple of questions. So we will take two, and as soon as I see them, I'll tell you what they are. Okay, Jerry, I don't know whether you can see these, but I'm going to read them anyway. So the first one is, can you comment on what is known about economic drivers and outcomes related to overdiagnosis and overtreatment in single-tier versus two-tier systems? For example, change to rates of inappropriate treatments and interventions.
I